Compare two fasted patients side by side. Patient A has been starved for 72 hours. Patient B just emerged from a major laparotomy. Patient A is in a state of strict physiological conservation. To preserve vital tissue, their body has actively suppressed thyroid and sympathetic activity, dropping their basal metabolic rate by 20%. They are hypometabolic. This diagram illustrates the divergence in metabolic activity. Patient A's gauge drops into a blue conservation zone. By contrast, patient B's gauge spikes into the red. The surgical trauma has triggered a massive neuroendocrine stress response that actively overrides the body's conservation mechanisms. In clinical practice, the adaptive response of pure starvation is frequently confused with the destructive, non-adaptive stress response triggered by surgery. Conflating these two metabolic states leads to significant errors in preoperative assessment and drug dosing. True starvation is a state of negative energy balance, where the body is forced to rely entirely on its own endogenous stores to maintain life. The immediate triage goal is the strict maintenance of blood glucose. Two obligate users, the brain and red blood cells, lack the capacity to use alternative fuels in the short term. The secondary survival goal is the preservation of structural integrity. If the body indiscriminately consumes skeletal muscle for energy, it will eventually destroy the diaphragm, leading to respiratory failure. This animation illustrates the physiological driver of this triage. As blood glucose levels fall, insulin production plummets. This causes the glucagon side of the ratio to rise and lock into an elevated position. This shift in the hormonal ratio alerts the autonomic nervous system, triggering an immediate release of catecholamines and cortisol into the bloodstream. This biochemical shift initiates a structured three-phase timeline of human survival. This chart displays the metabolic timeline of starvation. Phase 1, the post-absorptive phase, covers the first 24 hours of fasting. The body's first line of defense is hepatic glycogenolysis, the breakdown of glycogen stored in the liver to maintain circulating glucose. This defense is strictly limited. The liver typically only holds approximately 100 grams of glycogen. As the graph shows, these stores are consumed rapidly, exhausting completely within the 24-hour mark. Once the hepatic buffer is empty, the body must immediately find a new way to manufacture glucose, or the brain will starve. Phase 2, early starvation, covers days 1 through 3. With glycogen gone, the liver shifts its enzymatic machinery to gluconeogenesis, the creation of new glucose. The liver requires specific raw materials to drive this process, primarily pyruvate and amino acids sourced from outside the organ. To secure these amino acids, the body begins the destructive breakdown of its own skeletal muscle. This muscle breakdown presents a clear clinical marker: peak nitrogen excretion in the patient's urine. During this phase, the body relies on the Cori cycle as a critical metabolic loop. Red blood cells lack mitochondria and are obligate anaerobic glucose users. This means they constantly produce lactate as waste. The liver acts as a recycling plant, taking that lactate and converting it back into glucose for the red blood cells to use again. Phase 2 is ultimately unsustainable. Continued muscle breakdown will eventually compromise the respiratory system. Phase 3, late starvation, occurs after the third day. To prevent the destruction of the diaphragm, the body initiates a massive protein-sparing response. Metabolic priority shifts to adipose tissue, which begins releasing stored triglycerides into the bloodstream. Returning to the timeline chart, we see the muscle breakdown curve flatten as a new fatty acids curve sharply rises. This happens because only the small glycerol backbone of the triglyceride can undergo gluconeogenesis. The remaining free fatty acids cannot be converted into glucose. Instead, they are mobilized and travel directly into the liver. Through beta oxidation, the liver converts these fatty acids into ketone bodies, namely acetoacetate and beta-hydroxybutyrate. Through keto adaptation, the brain unlocks its ability to use these ketones instead of glucose. The brain eventually relies on ketones for over 70% of its energy, which drastically lowers the total systemic demand for glucose. In the final stage of adaptation, the renal cortex activates to handle up to 50% of the body's total gluconeogenesis. Metabolic adaptation successfully preserves structural proteins. Now, the primary limiting factor for caloric survival becomes the scale of the patient's remaining adipose reserves. These biochemical changes directly inform the preoperative anesthetic assessment of a malnourished patient. Chronic starvation decreases MAC requirements for volatile anesthetics, reflecting a more sensitive central nervous system. The preceding muscle catabolism often leaves the patient with severe hypoalbuminemia, a depletion of albumin in the blood. This creates a dangerous pharmacological scenario. Highly protein-bound induction agents, like thiopentone, now have a massively increased free fraction in the blood. Induction doses must be significantly reduced to avoid sudden cardiovascular collapse. Starvation also depletes hepatic glutathione stores. This depletion severely lowers the threshold for paracetamol-induced hepatotoxicity. A starved patient's physiology is a delicate environment where standard pharmacological dosing can prove highly dangerous. The most lethal clinical trap in starvation management is refeeding syndrome. Consider a scenario where a clinician administers standard intravenous dextrose to a malnourished patient. This sudden carbohydrate load abruptly reverses the hormonal ratio that has prioritized survival for weeks. In response to the glucose, the pancreas releases a massive, sudden spike of insulin. This animation shows insulin unlocking cellular transport. The hormone forcibly drives electrolytes out of the bloodstream and into the intracellular space. This precipitous drop in serum electrolytes can trigger fatal arrhythmias and acute heart failure. Understanding the metabolic timeline of starvation is the only way to safely bring a fragile patient back from the brink of systemic collapse.